Good morning, everyone. Thank you for joining the webinar organized by the GMOA Free Academy. And let me start with the housekeeping role. Here, the webinar link will be available from 9 a.m. to 9:45 a.m. to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the CPD guidelines. And this is to improve and maintain the standards of the CPD programs conducted by Sri and GMOA. Thanking you for the strict adherence of the CPD regulations and your kind compliance. Now, I would like to request you all of you to switch off your videos and keep your mics on mute. I kindly request you to type in your questions in the chat box. We can discuss on those after the webinar. I hope all of you will enjoy this webinar and find it very useful for your clinical practice. Without any further delay, I would like to welcome our lecturer for this webinar session. Dr. Krishan Dalpadadu, consultant pediatric neurologist from Teaching Hospital, Kurunagala, for his excellent lecture and precious time. Over to you, sir.
Thank you. Good morning, everyone. I would be discussing evaluation of syncope and management of prolonged convulsions today. Now, all of you would have recently heard about 20 children fainting in a school in Villachia. Now, this was all over Sri Lankan newspapers as well as newspapers outside the country. One newspaper had described the Sri Lankan children fainting as children falling down like flies. So it's a very today's topic that we are going to discuss about syncope and fainting episodes is quite timely and quite appropriate, I would say, due to the current ongoing situation in the country, as well as we would be discussing something very important as well for all of your day-to-day practice if you are practicing in a rural country, that is a rural hospital, that is management of status epilepticus, or what we call a prolonged convulsion. Now let's start with fainting episodes. Now, fainting episodes are described as a sudden loss of consciousness associated with the loss of posture and tone. Now, that happens very suddenly, very briefly, for a very transient period of time. If I take you to your basic sciences in your medical school days, now this happens due to activation of two pathways. You have the afferent pathway, which is the activation of your sympathetic pathway, and your efferent pathway, your afferent pathway, and your efferent pathway is the parasympathetic pathway. So if you suddenly feel anxious, if you feel something, if you feel tense or some situation is there, your sympathetic pathway is activated. And you will feel a prodrome of symptoms, lightheadedness, giddiness, dizziness, something like that. And then your parasympathetic pathway gets activated. What happens when your parasympathetic pathway gets activated is your blood vessels start to dilate and your blood pools in your vascular system without much circulation of blood to the brain. And that is when lack of oxygen to the head leads to this transient loss of consciousness. Once you drop to your neutral position on the ground, when you're flat, then your blood circulation is restored back to the brain, and then you regain consciousness. So syncope is a brief and a sudden loss of consciousness associated with postural tone and spontaneous recovery. What I just described to you is what we call the vasovagal syncope. So activation of the vasovagal pathways. Now, in children, not like in adults. Syncope is a very common condition. At least one or two children probably faints every once a week in the school assembly. But now this is taken out of context due to the current situation. Uh, so as you know, in the slide, it says 15% children experience episode before the end of adolescence. So before a child becomes an adult, at least 15% of children would have had at least one episode of syncope. So go back to your childhood days. I'm sure most of you here would have at least had one episode of faintish episode during their childhood. Now, as I said, most of you will get a child coming to your OPD, coming to you to see you in your private practice with episodes of faintishness. So when they come, you have to decide, is this something benign or is there something very sinister underlying? Now, that is the only thing that you need to decide. So am I dealing with a benign vasovagal syncope that I just described, or am I dealing with a life-threatening condition? And the sinister ones are only two conditions that you need to think about. I don't want to, there are loads of conditions that you have to think comes in the differential diagnosis when you think about faintish episodes. But all you need to decide is whether it is benign or whether it is sinister, or whether is there a life-threatening problem. Now, what are these life-threatening problems? Now, as I said, most are what we call neurally mediated syncopes, or what we call the autonomic syncopes, vasovagal, orthostatic hypotension, etc., etc. Those are benign. But the other things that you need to decide is whether this is cardiac, whether is it due to a problem in the heart, or whether it is neurological, whether this is, did the child fall down due to a seizure or a fit, as we call in a layman's term. So is it cardiac? Is it neurological? That is the only differentiation that I think you at your level that you need to decide when it comes to a child who presents to you with syncope. Now, so keeping that in mind, what are the differential, how do you differentiate, say, a seizure from a uh, vasovagal syncope? Now, usually, as I described earlier, are there precipitating event? Is one you when you talk about now these are all what we call paroxysmal episodes. So when you try to describe the paroxysmal episode, there is a event that happens just prior to the episode, what is called the pre-ictal or pre-event. Then you have the ictal, or the what you call the event, and then you have the post-ictal. That is for a seizure, but you can describe faintish episodes in the same way. Now, is there a precipitating event to the precipitating event to this episode? Now, usually for a vasovagal syncope, the precipitating event would be standing for a long period of time, even in the assembly during the morning prayers. The child had been standing for a very long time. Blood keeps stagnating in the legs, and there is not much movement of the legs to pump the blood into the heart. So has that been there? Has there been a painful or emotional stimulus? Was there sudden fear, sudden anger? Was there a sudden painful? Did the child hit something on the way while running, which was quite painful? Or did the child see something like, sometimes you see children fainting when they go to their investigations for blood investigations, when somebody tries to draw blood, either by seeing blood or doing the venipuncture procedure, they faint. So things like that. Has there been a precipitating event? So did something provoke this episode? That is the first thing. In seizures, a seizure is, in its definition itself, is a non-provoked event. So seizures do not have a provocative provocation. So, for instance, uh, febrile convulsions are not epilepsy because febrile convulsions are provoked by fever. So we don't take febrile convulsions as epilepsy. Now, so you have a usually a precipitating event, then the child falls down, and then what is the duration of this transient loss of or transient change in awareness or loss of consciousness? Now, in a vasovagal syncope, this is usually a very short period, few seconds, if I would say. In a seizure, from few seconds to few minutes, even it can last even longer, uh, half an hour, even longer if there's a post-ictal drowsiness. So if it's not a few seconds, you need to think, am I dealing with a seizure? Incontinence, usually you don't see in vasovagal syncope, you see it in seizures. What happens after the event is the next question. What happens after the event? In vasovagal syncope, the child usually gets up, child remembers what has happened, child remembers the friends shouting, teacher coming to them. What they usually do is put some wet cloth or water to the face. The child gets carried to the sick room. All these things child would remember. But in a seizure, child does not remember this. So there is no confusion in vasovagal syncope. In seizures, post-ictal also, their child would not be able to quite fathom what has happened or what is happening in the surrounding. Tonic-clonic movements, what you call the motor convulsions that we usually see. In seizures, in syncope, you might see one or two. It's not completely absent that you need to remember. In seizures, it's frequently present. Just because there was one or two jerks, don't jump in and think it's a seizure. But if it's, it has been going on for a few minutes, it's very unlikely to be a vasovagal syncope. So in essence, how do you decide whether it's a seizure or not? Is whether there a provoking event. Was there prolonged loss of consciousness would suggest seizures. Things like incontinence would suggest seizures. Now, what would more than seizures or a neurological event? It would be the cardiac problems that would be more sinister if it's causing syncope or what you call loss of consciousness. Now, when I was a medical student, I remember a famous cardiologist's son went on a trip with us to Kandy to Hantana, and he suddenly collapsed and he died. I had another friend who was a brilliant student at school, was doing very well as an engineer. In the parking lot, he was having a few syncopal episodes, talking about getting dizzy a few times, suddenly collapsing and dying. All these people died because they had cardiac issues leading to syncope. Now, how do you identify these conditions? One is that prodrome that we spoke about is not there. The prodrome that we spoke about in the previous slide is not there. And these people who have potential cardiac issues during or before the event will start getting palpitations in the chest, tightness in the chest. And some of these are induced by exercise. So if you rode a bicycle with strenuous exercise, like in the previous example I gave you, did some climbing. Those are, if it is induced by activity, then it is a red flag. Past cardiac history or a family history of early cardiac death arrhythmias are a potential red flag that you need to be aware of. One of the two friends that I described to you had a family history of cardiac issues in their uh, uh, immediate family members. Now, I'm not a cardiologist, just trying to talking about this because I'm not a pediatric cardiologist. I'm talking about this just to make uh, to drive home the point that when you see a child with syncope, if it's recurrent, your history is very important. You have to look at these, you have to inquire into these red flags to identify a potential cardiac etiology. As a non-cardiologist, when I get a child with syncope, I go through these just to make sure I'm not missing a potential cardiac problem. Now, physical examination again directed at looking at a potential cardiac issue. You can do the blood pressures, supine and standing. You can do the pulse rate, see whether there is any problem in heart rate. Usually, you're looking for bradycardia here, and you need to just step into the heart and look for clicks, gallops, and murmurs, all indicating problems with inside the heart. So you're looking basically at two heart issues. One is whether there is an obstructive issue to the blood flow in the heart, or whether there's a problem uh, 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 in the rhythm. So is it the arrhythmia or is it an obstruction? And the most important investigation would be a ECG. Everybody can do a ECG and have a look at the ECG. You don't need to be an expert in ECGs to sometimes identify issues. You can calculate the QT interval, look at the T morphology. These are to look at long QT syndromes, which are, again, sometimes can be familial. You can look at the height of the QRS complex to see whether there is a left or right ventricular hypertrophy, and you can calculate the heart rate, see whether all the P waves are conducted to a QRS complex. So these are basically few things that even a non-cardiologist can look at in the ECG and identify. Now, if the child presents early to you, sometimes they faint and they are brought quickly to you to the OPD or to the the nearest hospital or the nearest doctor. Useful investigation would be a bedside blood glucose test, or what we call the capillary blood glucose test, especially in the current context where there is uh, problems with food security, problems with children not eating, not getting a proper meal in the morning. So these are blood glucose level might be quite useful if you see this child shortly after the event, but not after a few hours or maybe a day or two afterwards. Hemoglobin level is also an important test. If you can do a full blood count, that would be important. Low hemoglobin can be associated with strenuous exercise and all that with syncopal attacks. Now, the diagnostic test is what is called a tilt table test. Now, this can be done in adults, but in children, you can confirm the diagnosis of a vasovagal syncope by doing the tilt table test. But I would not recommend that you send all these children to the to the tertiary hospital to do a tilt table test, because you don't need to do this. You just need to evaluate properly identify red flags. If there are no red flags for cardiac or neurological cause, diagnose a vasovagal syncope uh, and follow up with your next line of treatment. Now, this is a small algorithm you might want to remember when you see a child with syncope. One is, so you see a child with syncope, you look for cardiac red flags on history, examination, and ECG. Yes, they are there. You do a cardiac referral. Now, if there are no cardiac problems, you see whether this loss of consciousness has been lasting uh, for a longer period of time. Has they been there for not few seconds, few minutes, few hours, or like etc. And had there been any abnormal movements, abnormal posturing, tonic-clonic movements going on for a long time? Now that is a seizure. So you refer to the pediatric neurologist. If that is not there, there has been a precipitating event, like what I told you, prolonged standing, fear, pain, what etc. Then it's probably orthostatic hypertension or vasovagal syncope. It's orthostatic syncope. If that is not there, it's probably vasovagal syncope. Now, this is a simple algorithm for you to remember when you see a child with faints. So, how do you treat? You have now you don't rush and treat with medication. That is not appropriate. What you try to do is you try to use behavioral modification. If the child fades every time in the morning assembly, I think it would be appropriate for the parents to discuss with the principal and the teachers to give maybe a child a seat, because it's the prolonged standing that has caused this. If the meal times are irregular, if the child, then it would be best that that advice be given about the meal times. Now, this might be a difficult area to sometimes with the current situation. We'll have to decide how to deal with that, involving other stakeholders, maybe MOH, the midwife, etc. So identifying the prodromal symptoms. So sometimes identifying the giddiness, the dizziness, and when that happens, child sits down, puts the head down. Those things can prevent the episode from progressing into a fall. So that is what you need to do. Water and salt. Having that ready if the child has frequent faints and you have diagnosed vasovagal syncope is also useful. Sometimes doing all these behavioral modifications, giving water and table salt also might not help, and they're having frequent falls. You have excluded a cardiac problem. You have diagnosed that this is not a seizure or epilepsy. Then you might, in very few instances, decide to give beta blockers. Sometimes fludrocortisone has also been used, which has the same effect as giving water and salt. It increases the plasma volume, and that should be reserved for children who are frequently fainting. So that is for faints. Then we go on for to management of prolonged convulsion. Right. When you see a child with prolonged convulsions, these are, I think, a few questions that have been asked by generally consultants, middle grade doctors, interns, everybody. I have diazepam and midazolam. Which one is better? Is it better to use midazolam or is it better to use diazepam? Phenobarbital. Now, I have had a nurse when I was an intern in a tertiary care hospital. Every time she see there is a child who gets admitted with a seizure or a febrile convulsion, she would be behind me with the phenobarbital prepared in a vial, and she would pester until that phenobarbital is given. And if it's not given, she would even go on to the extent of calling the person senior to me, or even sometimes the consultant has been called and telling that this child was not given phenobarbital. So phenobarbital, is it a first line anti-epileptic drug? Now phenytoin, if you are working in wards, or if you are working in a bigger hospital, can we give IV phenytoin? Is it safe for children? There's a new drug called levetiracetam. I think you might have heard about it. IV preparations are available. It's available both in private sector as well as in government hospitals. Maybe not in the rural hospitals or district hospitals. Tertiary hospitals, definitely it's available. Can we use it? And then finally, if the seizures are going on and on and on, midazolam infusion. When to start the midazolam infusion? These are some of the questions that you face when you see a child with a prolonged convulsion. So these are some of the things that I just want to briefly discuss about prolonged convulsions, outcome definition, what is the first line anti-epileptic, what is the second line anti-epileptic drugs, maybe a guide. This is my guide, so I don't a guide that I have prepared to be used. So you can follow that if you want, and then something about the refractory status epilepticus. Okay, so uh, uh, it is definitely uh, a child who has a prolonged seizure going on to a status epilepticus. Nobody denies the fact that it will cause significant morbidity and mortality. So you have a recurrence at 60% at 1 year. At 4 years, 20% will get seizures. There are significant short-term memory problems, language problems, motor problems, issues with learning, which is the most important thing for parents and the child. And 13 to 74% go on to have epilepsy. So there's no denying the fact that prolonged seizures, status epilepticus, if you don't manage properly, ends up with severe problems to the child. Now, I'm sure most of you have heard the definition that a status epilepticus is defined as a generalized convulsion that goes on for more than 30 minutes. So child is shaking for more than 30 minutes for you to diagnose a status epilepticus. Or child gets these short convulsions. You get a convulsion, it stops. You get another convulsion, it stops. But in between the convulsions, the child does not regain his baseline level or baseline function. And that is also, if it goes on for more than 30 minutes, it's called a status epilepticus. Now, this is a very old, you can see, International League Against Epilepsy gave this definition in 1993. So almost 30 years now gone past. And this definition has now been changed. Why has it been changed? Because now majority of seizures we know will last for 5 to 10 minutes and they will spontaneously stop. So you don't need to do anything at all, and majority of the seizures will stop. And the mean duration of a seizure going on would be around 12 minutes. So if we say 5 minutes, 45% will go on to get prolonged, 10 minutes, 23% more than. So seizures more than 5 minutes would be 45%. More than 10 minutes would be 23%. Only 6% of seizures would last for more than 30 minutes. And you can see that in a study, 92% of the seizures have stopped spontaneously. So if you don't do anything at all, seizure would stop. 9 out of 10 cases. But the problem is not that. The problem is when the child comes seizing to you, imagine the whole situation. parents are shouting and crying. Sometimes the whole village is outside your hospital. Uh, the other staff, the nursing staff, the attendants, everybody is rushing around trying to get this drug, that drug, oxygen. You know, it's a whole chaotic situation. So if you don't know what to do at that moment, as you are the team lead, sometimes you are the most senior person, you are in a lot of trouble. But this is to say that most of these seizures will anyway stop spontaneously. So you don't need to do anything. And that is an important aspect, because what I see is that as soon as the child is rushed into the OPD, what you do is you take a diazepam and you uh, inject it as quickly as possible, or you put a cannula in and try to give midazolam or phenobarbital or whatever. Like I said, that what the nurse did. Try to give a drug. Try to give a drug to control or stop the seizure as soon as possible. And by trying to do so, you end up uh, pushing this drug too fast into the child's system, and you will get a child whose respiration then goes off and the child stops breathing. And that, has been a problem few times in some of the hospitals where, in rural hospitals, where the child stop breathing spontaneously. You might not know how to do the emergency airway breathing circulation procedures, and then try to take the child to the next nearest bigger hospital. Sometimes child, at least one incidence, a child had died, and then uh, the whole village then gets agitated. There's altercations with the hospital and things like that has happened. So first thing is, you do not need to act as fast as think you need to act. So you can wait for 5 minutes. This is again the duration of the first seizure. 76% of the seizures, the mean duration is around 4 minutes. 24% of the seizures, the mean duration is 3.1 minutes. So if a seizure lasts more than 7 minutes, only there would be a probability that the seizure would not stop. Now, with these findings, the ILA has decided to change the whole definition. One thing is that 30-minute definition has created such a lot of havoc. Either it tells you to wait for 30 minutes to do something, or the other thing is you don't want this to go for 30 minutes, so you are acting as quickly as possible to control this seizure. Either way, you are not managing the child properly. So what they have done is they have defined two timelines into the seizure. If the seizure goes on for more than 5 minutes, it's called the early status epilepticus. So you need to act only after 5 minutes. So during that first 5 minutes, you can watch and wait. There are other things that you need to do, but not give anti-epileptics during the first 5 minutes. But if the seizure goes on for more than 30 minutes, that is called an established status epilepticus. That is where when the brain damage to the child's brain starts to start. That is 30 minutes for a prolonged conversion, for a motor conversion. This is just what I need to. For a motor conversion, T1 is 5 minutes. T2 is 30 minutes. That's all you need to remember. Others are just information. So if the child is convulsing, you need to start treatment at 5 minutes. If the seizure goes on for more than 30 minutes, you need to start expecting consequences of the status epilepticus. So that's all you need to remember. So first phase, so there are 4 stages here. What we call the first stage, or the early phase stage, or the premonitory stage. what you call the established impending status epilepticus, that is for the first 5 to 10 minutes. Then the next 10 to 30 minutes is the established status epilepticus. But when it goes beyond 30 minutes, it's called a refractory status epilepticus. And when it goes beyond 1 hour after treating with at least the appropriate true anti-epileptic agents and requiring anesthesia, then it's called, if it goes more than, goes beyond 1 day, it's called a super refractory status epilepticus. I don't, this is just for if somebody is interested in doing postgraduate studies, what you need to know is the first 5 minutes, after first 5 minutes, you call impending status, becomes a established status. And after 30 minutes, it becomes a refractory status. So what are the first line drugs to use? The 3 drugs are diazepam, midazolam, lorazepam. As far as I know, lorazepam is not available even in tertiary hospitals. So you are left with 2 drugs, diazepam and midazolam. You can see here that the receptor affinity of midazolam is higher than diazepam, and the duration of action here is higher in midazolam than diazepam. What this is basic sciences again. What this tells you is that midazolam attaches itself and stays attached to the receptors for a very long time compared to diazepam. So by giving the midazolam, you can prevent a recurrence from happening. You can expect a better resolution of the convulsion than giving diazepam. And on the other side, midazolam has lesser problems with respiratory issues, like what you see when you give diazepam quickly. Respiratory suppression is not seen as it is there in midazolam, but it is lesser in midazolam than in diazepam. So overall, in the place that you are working, it's better for you to ask for midazolam, procure midazolam than having diazepam. But if you don't have, midazolam, don't think that I don't have midazolam, I can't give diazepam, then you have to give diazepam. Now, which route to use? People say give buccal, give PR, but the best route is always intravenous, always intravenous. So that is what is being shown. Giving the drug intravenous will help control the seizure quicker than giving buccal or PR. Obviously, because you are injecting straight to blood. Otherwise, what happens is it has to go through the first pass metabolism to the liver and then to blood. If you give any other route, it has to get absorbed before going to blood. So giving IV is much better than giving any other route. So IV diazepam, versus intranasal. So if you have, say, IV diazepam, and but we have is midazolam is what is called intranasal or intrabuccal, then midazolam is much better even when it's given through other routes than IV diazepam. So as I said, the recurrence rates are lower in midazolam. Respiratory insufficiency is lesser in midazolam and lorazepam compared to diazepam. The next issue is giving repeated doses of a benzodiazepine, that is either midazolam or diazepam. Now, if you give more than 2 doses of benzodiazepines within 24 hours, the risk of respiratory insufficiency increases. That you need to remember. Sometimes this child goes to the general practitioner, he gives a PR diazepam, he comes to the OPD outpatient department emergency room, gets a diazepam or midazolam, it doesn't settle, and then you try to give another one. And the third dose will very likely cause respiratory depression, and you will have to intubate and ambue the child. So that is something that you need to remember. Now, second line drugs, we have pitone and phenytoin and levetiracetam and valproate. Out of that, IV valproate is not available. Other three drugs are available. Now, what is important is now giving two of these drugs. So you give phenytoin, and then if the seizure does not settle, you give phenobarbital, you give levetiracetam. Then combining these two drugs, not giving together, but I'm saying sequentially, uh, has been shown to reduce seizures much better and reduces the incidence of this child being sending to the ICU. So how do you manage a prolonged convulsion? These are what I just discussed were some of the basic principles of managing. Uh, uh, you need to confirm that this is not a pseudo seizure or syncopal attack or breath holding attack or whatever. This is a seizure that you are seeing. And then first 5 minutes, calm down and think of airway, breathing, circulation. That is all you need to do in the first 5 minutes. Look at the airway, put the child in the left lateral position, suck out secretions. If there is something obstructing, suck it out. Don't try to put, anything inside the mouth. Don't try to sweep out anything out of the mouth. Give oxygen, high flow oxygen as soon as possible. Get vascular access. If you can get to a cannula, that would be great. But once you get vascular access, you need to do a capillary blood sugar. So that is, you don't forget the capillary blood sugar. We do that because it is not the seizure that will kill the child first. It is airway obstruction, breathing issues, and then the circulatory issues, hypotension, or things like that. Those are the things that will kill the child before the seizure. So remember that you don't attend the seizure immediately. As I said when I started this, you have about 5 minutes before you need to inject or give the anti-seizure medication. Now, your disability assessment, you look at the conscious level, posture, and pupil size, which I teach in APLS. If the child is seizing, you are not going to do a conscious level. Posture, pupil signs might indicate whether there is, looking at the pupils are important during that first 5 minutes. It might indicate if you have an unequal pupil and if you don't have much of history and this child is unconscious. It might indicate that the child has had a trauma or there's a bleed inside the brain, there's raised intracranial pressure, something like that. So looking at the pupils are a very important sign during that first 5 minutes. As I said, don't ever forget glucose. And in the same instance, you need to think there are other reversible causes to this seizure. So what are the other reversible causes? One is high blood pressure, intracranial problems, bleeding, infection, ICP, electrolyte issues. So those are also, when you can do a blood pressure, you can send blood for electrolytes, you can look at the pupils to identify if there's anything inside the brain, if there's a bleed inside the brain. And once you get the cannula in, the seizure is likely to go on and on and on. Make sure you give a dose of antibiotics as well. Now, I'm talking about emergency management here of a prolonged seizure. Now, this is what this is my guideline, or this is something that I have devised. So this is not anybody's guideline, or this is not something, put out by any body or as such. This is from available evidence that I have done to, ease my management. So during the first initial phase, first 5 minutes, you do the stabilization of the airway, breathing, circulation. You look at the reversible causes. That's why I put check RBS. And after the first 5 minutes, the seizure is going on. So at that 5 minutes, it's very important that you have got the IV line in. So you give, if available, give midazolam. If you don't have midazolam, give diazepam. Now, if you have failed to put the IV line, then there's no other way, but you will have to give either IM, intrarectal or intrabuccal uh, benzodiazepine, midazolam or diazepam. Now, seizure goes on for another 5 minutes. Then you would give a second dose of your benzodiazepine, what you have, midazolam or diazepam. Again, by this time, you must have a IV line in or intraosseous line in. But if you don't have, again, if you are still scared to put IV line or intraosseous line, then you might have to think about the other routes. If the seizure goes on for another 5 minutes, then give phenytoin, levetiracetam, or phenobarbital. And if you have given levetiracetam, you can wait for 5 minutes. If you have given phenytoin, you can wait for 20 minutes to give the next dose. Now, problem with phenytoin is potential hypertension and arrhythmia. So you need to make sure that you give it with cardiac monitoring. At least the rhythm strips and a monitor on when you give it, and you don't push it in. It's an infusion that goes on for 20 minutes. If the seizure does not settle after 20 minutes, after giving levetiracetam or phenytoin, you can change over. So if you have given levetiracetam, you can give phenytoin. If you have given phenytoin, you can give levetiracetam, or if one of those are not available, you can give phenobarbital. But even with that, if the seizure does not settle, then this child needs to be intubated. Child needs to be ventilated, and you need to start a midazolam, propofol, or thiopentone infusion. Usually, what you would have is a midazolam infusion that is available. And if the seizure settles while you do this, you try to identify what has caused this prolonged seizure. It might not always be epilepsy. It might be an infection. It might be that the child had missed a dose, or it might be intracranial bleed. It might be electrolyte issue, something like that. So identifying and treating the cause of the prolonged convulsion is as important as going through this algorithm. But here, I think if you are ruling a very rural hospital, you might not need to go through the whole algorithm here. Uh, uh, Maybe after 2 doses of benzodiazepine, so you will have to consider transferring this child to the next available bigger hospital. And if you just count the minutes, by the time you intubate, it has taken 5, 10, 15, around 40 minutes. So what this guideline I'm trying to show is, by at least 30 to 40 minutes, you need to make sure that the seizure is under control. If the seizure is not under control, intubate the child and start something that will start an infusion of some sort with the 3 drugs that I have mentioned. These are just a few things that I think I've prepared for another lecture. So if the seizures does not settle even in the ICU, you need to think about ketogenic diet. You need to think about immune therapy, which is IVIG, and IV methylprednisolone. So those are things for somebody who wants to postgraduate studies. So refractory status epilepticus, treatment and management. So I think we have come to an end of the lecture. You might be wondering why I have this glass of whiskey on the screen now. So and it is an interesting fact that the whiskey has this substance that causes activates GABA receptors and reduces potential for seizures. So something interesting for people to know. So I'll stop there and take on questions.
Thank you very much for this informative session, sir.